Just briefly, I want to touch base on immune therapy. The rest of the world is, not the rest of the world, much of the world is enjoying a blossoming of immune therapy. The surprises in lung cancer, we already kind of knew renal and melanoma was going to mature. We're still behind, and a lot of research, I'll just sort of summarize, a lot of research going on, checkpoint inhibitors, immunotherapy vaccines in GI cancers. I think colorectal has not been one where there's a lot of traction. Yes in HCC, yes in panc, yes in gastric GE junction. We haven't seen as much in colon, but not as if we're not trying. Because we believe, the immune therapists out there believe that you don't need to know about all these pathways if you could train the immune system, because it'll learn for you and go on. Anybody have other experience or additions on immune therapy?
So that's, of course, that's a big effort. Part of it is prying the agents out of the pharmaceutical companies who have sort of down-regulated their enthusiasm for colorectal cancer. If you look at the prognostic factors for a patient with a new diagnosis of colon cancer, lymphocytic infiltration is an important factor. No question that it's relevant. The cooperative groups are planning a couple of forays into immune therapy. We have to walk before we can run, perhaps, make sure we believe colon cancer patients on average will mount immune responses. They tend to be well-nourished, in good health, but we need to get there. I think in the study that will look at mutations, that will look at buckets of mutations, the truth is 60% of patients probably won't have any kind of mutation that we would know of. Those are patients who might be ideal for an immunotherapy. So we have to start fast.
Last thing on this area is I'm going to go starting down here and work that way. We're coming to you from San Francisco at the so-called GI ASCO. It's actually not officially called that, but that's what we all call it. This is a meeting where new data are presented. Starting with Johanna and working down, so you have the hardest job, what is being presented here that you think the gang at home who didn't make it to 75 degrees San Francisco in January, what should they know that's been presented here?
Practice changing data, do the expanded KRAS analysis in all of your patients, look for the BRAF mutated patients, and look for them early.
Get this done, get it done tomorrow.
Yeah.
Okay?
She's my spokesperson.
No, come on. That's why it's going to get harder as you go. Is that it? That's it?
I think from
3 days of meeting?
From the scientific point of view, we will hear new data in addition, because we mentioned about even when we have RAS testing, does not predict response. It increases likelihood. So what additional markers of how can we expand our panel? And we will hear data on tomorrow, actually, on the FIRE3 data, where we look at the role of PI3 kinase, the role of BRAF in this patient population. So I think these are important data in understand the predictive and prognostic role in it, and particular where we now have treatment options. So I think this will advance our understanding in our testing for these particular mutations.
Have you got one?
I have to second or third. I think it's prognostic predictive. That's the theme. And I think one thing we have to also keep in mind that as we find out these KRAS and all extended RAS assays, and you look also at the chemo outcome of those patients, those are actually patients who have a better prognosis even when they don't get anti-HFR therapy. But definitely patient selection is the theme of this meeting.
Alan?
Well, so what we won't hear at this meeting is data on 80405, but what we will hear almost certainly is data on 80405 at the meeting in June, and that will, I think, free up the logjam as to what we do next and what direction to go. It'll be clinically important. It may not have great effect on research initiatives for the time being, but that's important data. And then sorting through the biology of what's going on there, 80405 will have an immense correlative science component where we will have an amazing opportunity to look in detail at this. Heinz is really in charge of the translational component. So what I would say is looking forward, once we get that data, we can, if we can't sort things out with that data,
we will change the world.
We potentially could figure out the disease and get us a long way towards understanding how to treat which patient.
And for those who've never been to this meeting, if you really do have an interest in GI and GI cancers, it's really a fabulous meeting. It's multidisciplinary. It's surgeons and gastroenterologists and radiation oncologists and oncologists. It goes through each of the diseases. It's small enough, if you will, that we actually can talk to each other and think about the data. whereas the June meeting is really just a sprint the whole time. So for those out there who do have an interest in GI cancer, if that's your thing for your practice, this is probably a worthwhile use of an end of a week in San Francisco in January. So again, thanks for using your crystal balls and looking for what's ahead. It does look like exciting times.